So I think next we have Dr. Meijer.
Yes, I'm here.
Wonderful. Thank you for joining us, and please feel free to go ahead.
I'm just going to make sure I have access to the slides. Wonderful. So hi, everyone. My name is Inge Meijer. I'm a pediatric neurologist at CHU Saint-Justine in Montreal, specialized in movement disorders. Okay, just trying here to get access to my slides. Okay, sorry, I had trouble with. I have no conflict of interest to declare with regards to this presentation, other than the fact that I'm not a leukodystrophy expert, but more a movement disorders specialist. So in the question period, if there's something that's very specific to leukodystrophies, I might ask the other experts to chip in and if the question is too difficult for me. The other thing that I wanted to mention is that in the initial schedule, I had put hyperkinetic movement disorders, but I decided to actually touch on several movement disorders. Movement disorders, when you go see your doctor, have different names, and they're based on clinical characteristics. Whoa, it's moving along on its own. And there are many, and I'm not going to talk about all of them, but I'm going to try to explain some of these, which are most frequent in 4-H and other leukodystrophies. They are caused by, all of them except for ataxia are caused by dysfunction of the basal ganglia, which are not that often affected in leukodystrophies. And we more think that maybe the connections to the basal ganglia, the white matter connections to the basal ganglia, are affected in leukodystrophies and can lead to movement disorders. So they're not as common as spasticity, which Dr. DeLange just addressed in leukodystrophies, but they shouldn't be overlooked, and they have some specific treatments. So it's important to distinguish the two. And so the most common ones that have been reported in leukodystrophies, notably in 4-H, are dystonia, a term spastic dystonia, which is not necessarily generally accepted. So I'm going to talk about that. Tremor, I'm going to touch on a little bit, Parkinsonism, and ataxia. Basically, what I'm going to do is not try to make you experts in these movements, but just give you a flavor of what these movements may look like and what their definitions are, so that when your clinician, your physician talks to you about these symptoms, you know a little bit what we're looking for and what we're thinking of. And then there's a whole other set of movement disorders, so myoclonus, bulismus, tics, etc., which are not really commonly seen, even less commonly seen. So we'll start with dystonia. Dr. DeLange already talked about it because it has to be distinguished from spasticity, which is the subject that she mentioned. Dystonia is characterized by abnormal muscle contractions that can be sustained or intermittent. So it's not always, hold on, the slides are moving on their own, I'm not sure why. That cause abnormal postures or abnormal movements that could be tremulous, so be a tremor, an abnormal tremor. And what's specific of dystonia, that it's often initiated or worsened by a voluntary action. So oftentimes we can have a child that looks like they have no dystonia, but when you ask them to do a rapid movement or to do a task of some sort, like write, then the dystonia comes out. And that's why it's often overlooked, because it's not always obvious at rest. In the more severe cases, it can be present at rest. What Dr. DeLange just touched on, it's important to distinguish spasticity from dystonia because the treatment is different. And a common tool that we sometimes use is the hypertonia assessment tool, because spasticity and dystonia are both tightness of your muscles. And basically there's different causes for tightness of muscles. And in my talk, I'm talking about dystonia, and Dr. DeLange talked about spasticity. And there's different clinic, without you you knowing how to use this tool, but there's different clinical clues that we use to distinguish spasticity from dystonia. One of the things I already mentioned is that when you have a voluntary action, dystonia gets worse. Sometimes when you touch the patient, the dystonia can be triggered, and the dystonia will be the same. The increased stiffness will be the same in both directions, whereas in spasticity, it's more in one direction. When the child is severely affected and has very little spontaneous movement, it can be hard to distinguish spasticity from dystonia. And I would guess that in leukodystrophy, patients often have a combination of spasticity and dystonia, which is where this term of spastic dystonia comes from. So I tend to see more and more spastic dystonia in many types of patients with cerebral palsy, but also in patients with certain forms of leukodystrophy. The symptomatic treatment in dystonia are similar to spasticity, but different. And unfortunately, in children, and I know there's not only children affected by leukodystrophies, obviously, the studies for these medications are quite limited. So the most commonly studied and where there's the most data for is trihexyphenidyl, which is the first one, and its commercial name is Artane. It's easier to say, so people tend to use Artane as the main name. And that one works really well, but it's not always tolerated, and even less tolerated in adults. So it's much better tolerated in children. The average dose to have a good effect is about 15 milligrams per day, but we do have children with, very much higher doses if we go slowly. So we have to start low and go slow. The main side effects are basically drying up different organs. So it dries up the mouth very much, so that can help for drooling. Sometimes it makes the secretions thicker, however, so sometimes that's harder to control the saliva. It can constipate, and since constipation in leukodystrophy and 4-H is a problem, that has to be monitored, and I often prescribe a laxative in conjunction with the Artane. And it can lead to urinary retention, which is the one that's a little bit harder to monitor if the children are nonverbal. So you have to keep an eye on changes in urine output in these children. Another medication is atopropisine. The commercial name is Parasitan, which is not really available in the US, but it's one that we use in Canada when Artane, the trihexyphenidyl, is not tolerated, and can sometimes be an interesting option. Dr. Delange talked about benzodiazepine, so there's many of them. The main side effect, though, is that it causes lower tone, and we don't necessarily want that. But it can be used at certain doses, and we're monitoring the low tone and the increased secretions. Baclofen is more of a spasticity medication, but it can help for dystonia as well. Levodopa is interesting as a medication, and I'm going to talk about it again. Tetrabenazine is often used also for dystonia, but I find that it's much more useful when it's dystonia mixed with chorea, which is another movement disorder. And I'm going to talk about that in a bit as well. Other options are botulinum toxin injections at lower doses than what Dr. Delange talked about, usually in the affected limb. So it's more interesting when there's one specific limb that's more affected, or in the neck that we want alleviation from pain, for example. Deep brain stimulation, I'm going to talk about. Intrathecal baclofen, Dr. Delange showed you just now. It's more for spasticity, but it can help certain severe forms of dystonia if they have an oral response to baclofen as well. Obviously, rehabilitation is key. So physical therapy, occupational therapy, and something that maybe others, I heard a mom speak about neuropsychological assessment, but sometimes psychological follow-up is interesting because dystonia is worsened by anxiety. So if we have a really anxious child, sometimes it's interesting to have psychology involved to help with decreasing the anxiety in the child. So DBS therapy stands for deep brain stimulation. These are electrodes that are implanted in the brain. For dystonia, usually the target is the globus pallidus interna, GPI. It's invasive. We permanently implant electrodes in the brain with a risk of infection, a risk of bleeding, which is not a high risk, but there is a risk. And it's recognized as a treatment for dystonia, but there has been no reported patients implanted for 4-H dystonia from what I saw in the literature. There is good data that it works for different kinds of causes of dystonia, because obviously 4-H is one cause of dystonia, but there are over 200 causes of dystonia. Certain forms, genetic forms of dystonia respond better than other causes. For example, in cerebral palsy, the response is less good. So I'm going to show you a video in a bit about with patients who've undergone DBS therapy. So I just wanted you to be aware of it. It's been used in certain forms of leukodystrophy with somewhat of a success, not always. I quickly wanted to touch upon status dystonicus, which is an emergency, medical emergency, where the patient basically gets stuck in their dystonia. Their dystonia gets so bad that they have trouble breathing from it. I think that in 4-H, since it's not severe dystonia, the chances that there will be status dystonicus are very low. The common triggers are quick medication changes, infections, and the reason I'm talking about this is that the main treatment, there's treatments that we give urgently to status dystonicus, and DBS therapy can be used in status dystonicus as well. But the main treatment is to prevent status dystonicus, so to adequately treat dystonia early on if it's present. There's not a lot of data for this, but most clinical experts will agree that you should treat dystonia. Dr. DeLange also mentioned medical cannabis. CB1, so cannabinoid receptors are highly expressed in the basal ganglia, which are the cause of these abnormal movements. There's many different mechanisms proposed to why it would work in dystonia. We think that these receptors, if they're stimulated, they might reduce the overactivity of the globus pallidi that cause dystonia and therefore reduce dystonia. There's not a lot of data. There's a small pediatric Israeli study where they looked at 25 patients with various movement disorders, including dystonia, where the patients reported improvement with scales, but it was not a randomized controlled trial. In panthokinase neurodegeneration, you also have subjective benefits reported by the patients, but there were no objective studies done. Health Canada has provided a guideline for clinicians and has reviewed the different studies available for each neurological condition. And basically their statement is that inhaled cannabis, so actual cannabis, not CBD, can improve dystonia in very small self-reported studies. And oral CBD oil could also improve dystonia, but the synthetic, so the Nabilon, Satifax, or basically synthetic cannabis does not show any benefit. So the data is very limited, but suggestive that it might actually help. To come to the second part, I'm going to go a little bit faster. So the chorea is not always bothersome for patients. In that specific patient, it was very bothersome. So you should only treat it if it really interferes with the movements. And that, I think, in leukodystrophies, depending on the baseline function of the patient, is really important. There's so many things going on, dental, gastro, etc. As in Dr. Van Haren's presentation, you really have to see which of these different symptoms cause a problem and which ones do we address. Doesn't mean that if they're present, we should always treat them, because all our treatments have side effects, obviously. So in chorea, in these patients, I would recommend tetrabenazine if the chorea was bothersome. Some people will prescribe antipsychotic drugs such as olanzapine, quetiapine, risperidone is one of these that we could consider at low dose, but these antipsychotics can worsen Parkinsonism, as can tetrabenazine. Sometimes you can try anticonvulsants as well. Parkinsonism is the last one. I don't have a video of Parkinsonism. Is a movement disorder defined by the acronym TRAP, so tremor, shaking, stiffness, rigidity. Akinesia means extreme slowness, and postural instability, meaning lack of stability when standing. It's often overlooked because it's not always a bothersome symptom, especially if the child is wheelchair bound, if the patient is wheelchair bound. But it's something to look for because levodopa can sometimes help. And especially, for example, if there's a lot of drooling because the face is just open and moves very little, sometimes it can help. It's not a treatment for drooling, but if there's Parkinsonism, sometimes those signs of slowness can improve with levodopa. The side effects I didn't talk about much of levodopa are nausea and vomiting. So it has to be given with a bit of food, fatigue, but overall it's very well tolerated if given slowly and slowly increased. So I found one case of POL3A related leukodystrophy, an adult case who had Parkinsonism and was implanted with a DBS therapy who had benefit from that. So I thought it was interesting to mention because I mentioned DBS therapy before, and I had said that there was no cases reported for dystonia, but there is this one case for Parkinsonism in POL3A, which brings me to the conclusion. It was quite quick. I hope I highlighted the movement disorders associated with 4H and other leukodystrophies, but I tried to focus on 4H. We reviewed their symptomatic treatments of those movement disorders. And lastly, even though many of these treatments have not been backed by scientific studies, detailed scientific studies, there's a lot of research going on to understand the mechanisms. And that's my research interest, for example, in dystonia and other movement disorders to develop better therapies. So that was it for me. I thank you for your attention. Thank you for the invitation to participate in such a wonderful family-oriented conference.